we only get rid of the problem in the bone marrow. So the Fanconi anemia is gone in the blood, but it's still in the rest of the body. That means that Fanconi patients, also after a bone marrow transplant, are still at the risk for developing cancer elsewhere, especially in the oral cavity. So that's very important to mention from the beginning on. We have heard a lot about these cancers now, and here are two examples: a very nasty cancer at the tongue and a very little one at the gingiva. So you heard a lot of things, but I would like to make some clear point and statement. Not every FA individual will develop squamous cell carcinoma. It is very important, and I really like that the awareness and the knowledge about these cancers has arisen in the past a lot, but still we do not need to be too much frightened of these cancers. So it's like the hematological issue in Fanconi anemia. Not all Fanconi patients needed bone marrow transplant. Not all Fanconi patients suffer from low blood counts. And that's the same also with this squamous cell carcinoma. Not all FA patients will get these cancers. But compared to the average population, the risk, the pure risk to develop these cancers is much higher. So that's why we talk about these cancers. And of course, they are life-threatening and a life-threatening complication. So when I look back 20 years ago, when I began to work in the FA field, most of the patients had the problem and died due to hematological issues. Luckily, due to the more advanced bone marrow transplantations and the higher success rate, this is not anymore the case in our days. So more and more Fanconi patients reach adulthood, which is really a very important progress over the last years. And the Fanconi support groups have done enormous work on that. So that's really something to have in mind, that we together can do something about life-threatening complications. And we haven't got still 20 years ago to just say all the patients will die due to hematological issues. So we worked against that, and I'm very hopeful for the future that we also can find our ways in terms of these cancers. So again, as said, these cancers are more a problem of the adult Fanconi patients. There are some few examples of younger Fanconi patients, but I would like to go into details later on that. So, and that is hematopoietic stem cell transplantation. David Cutler already mentioned that very extensively. Here you see a chart, and this is the ages of the Fanconi patients, and here's the cumulative incidence. And you see two different curves. This is the one, these are Fanconi patients who received a bone marrow transplant or hematopoietic stem cell transplantation. And here are the ones who have not been transplanted. So you see the risk for developing cancer increases with age, and the ones with a bone marrow transplantation got these cancers a little bit earlier, and the likelihood to get these cancers seems to be higher. In the past, there have been done many research on that, and the hope was that with the newer protocols, this difference will be eliminated. So far, we have not been able to show that, but one of the major risk factors for the transplanted Fanconi patients was the appearance of GVHD. So this is something to have in mind when you go to bone marrow transplantation, to take good care about GVHD. So we already heard that the squamous cell carcinoma are mostly located in the head and neck area. So this means the oral cavity, but it also can appear in the pharynx and in the esophagus, and also in the anogenital region. My talk will focus on the head and neck area, but we don't have to forget these other areas as well. David also showed that Fanconi patients, unlike the general population, seem to develop numerous squamous cell carcinoma, and that local relapses, so that the cancer comes back at the area where the cancer was, is a little bit more increased than in the general population. And that also secondary tumors, so again, more than 2 years after the first appearance of a cancer, can occur frequently. This doesn't mean that the treatment facilities and the treatment options are not good as in the first case, but of course a relapse is always not something to have that we want to see very likely. So these cancers, sometimes when we have done already a large surgery, are a little bit more difficult to treat. And the treatment options, David already mentioned them very nicely. The surgery is the way to go, and that's why we need early detection, because then the surgery is small, because all other therapeutic options are limited. There are new drugs approaching, like PD-L1 inhibitors or targeted therapies, very promising, and already the first patients with very good and nice results. In the past, we have known that these Fanconi patients developing these tumors have had a poor prognosis, and you see the timing after diagnosis, the ones to survive, seems to be a very bad prognosis. But this has been due to late tumor stages, and I would like to show you what late tumor stages means. When you hear all this information, you can say, okay, I don't want to listen anymore because it's already too much on my shoulders and the burden is too big. And we have this nice tradition at Camp Sunshine to have these wish boats. So we can make big wishes for the future, but we can also take action for the future. And this is what I very much like in the Fanconi field. Also at CAM, it is not to be too much afraid, because when you are too much of afraid, you lose your option and you lose the time to fight for yourself. And I would like to show you, this is a graph. So when we talk about the higher risk in FA, why do we have this higher risk? And the answer is so far not easily to answer this question. So we have some internal problems in FA. We have the genome instability. We know DNA repair is not so correctly done like in normal cells. We have problems with our immune system and many other issues that is typical for Fanconi patients. But these internal system, we cannot, or only very little influence, but we have a lot of things coming also from the outside, like, for example, carcinogens like tobacco or alcohol. We have nutrients that have an impact, especially on our epigenome. So we heard yesterday and on Friday a lot about what to eat, and that's very important because it has a huge impact of our cells. Also, David Cutler spoke a lot about infections, for example, the HPV. Also, inflammation plays a huge role in the cancer development. So there are many things that you really can have in the hand. There is not all what you can control, but there are some things that you can control. And on these things, I would like to go into more detail. And this is what I mean to be proactive. This is a Fanconi patient, many of you know, and he had bone marrow transplant and cancer for several times, and he is doing very nicely, very well, is married, and he is very proactive fighting for himself, and that's why he's still alive. And I think this is the way we all have to go. So I would like to go through 4 proactive steps against cancer with you. So the first thing is you need to have the information, and the information needs to be a Fanconi-based information. With general information from the general population, we can work a little bit, but we always have to find what is true from the general population for Fanconi. You know that you are special, and that's why we have to focus on what is special information for Fanconi patients. Then I would like to show you something about the surveillance. That means how to take care of your oral cavity. We will talk about some don'ts, and we will talk about the to-dos. Coming to the first point, information. I, as a German, like soccer very much, and I like this picture because this is a goalkeeper who will probably not keep any of the ball because he is blinded. He's standing in the rain, but he is blinded. So we need to get away this blindness. We need to have this information. So, and I just said that cancer and surviving correlates with age. And this is something what is true for the general population. And stages means stage 1, when the cancer is little, you can easily cut it out. Stage 4 is a very advanced cancer, and there are already metastases, so distant the cancer has spread. And these patients, even in the general population, they have a very low survival rate. And where is the information here for Fanconi patients? For the Fanconi population in the past, unfortunately, most of the patients have been diagnosed with stage 4, so in these very bad stages. And this needs to be changed. So we can, when we focus on early detection, we can have good survival, and we have these examples also in our Fanconi community. And this is very much to be improved, that we move from this half of the patients to only little of the patients, so that most of the patients should be diagnosed in stage 1. How can we achieve this? We have to know, and this is also something what you have seen from David Cutler, cancer does not arise from one day to the other. It has a history. It needs to develop. This is a drawing of the oral mucosa. Here you see this is inside of the body and this is the outside. And you see the oral mucosa, here's a basal membrane, is built up out of these cells sitting on this basal membrane. And sometimes changes in few cells can happen and can occur. And I must say this happens in all our body, in me, in everyone else, just by what we eat, what we have. So changes in the cells are very frequent. So how can they occur? You have, again, internal factors and external factors. Most of the internal factors in Fanconi anemia we cannot change, but the external factors we can have an impact on. So drinking and smoking, you saw the data, is not something to advocate, to do as a Fanconi patient. Also, we know when we have a bad oral hygiene, this means chronic inflammation, then the immune system has a lot to do, and sometimes they are so overwhelmed with fighting these bacteria that they forget to clear off these cells. Also, lack of micronutrients like special vitamins can happen, that the immune system is not so much effectively working against those cells. And again, infections from the outside can also bring problems like the polyoma viruses or other viruses. So this is something to have an eye on. Because the good thing is that these changes can be reverted back to normal. But what happens if these changes are not reverted? Then these cells start to grow because they have a growth advantage, and then they already start to change. And under the microscope, this is something what we call dysplasia. And this is a mild dysplasia. Looking from the outside, mostly you already can see mild dysplasia. And here's a little example of a very little tiny lesion, 1 to 2 millimeters of the size, very easy to miss, but sometimes also these lesions are bigger. And also the immune system is capable to get rid of all these cells. And there is already, again, this way back and forth. So even if you have something like that, you can cut it out, or sometimes the things heal and then it's gone. So even if you see something, this doesn't mean that you are on the track to cancer, but mostly if these things disappear after 3 weeks, then you can be sure that the process is going backwards to normal. What happens if this doesn't happen? So if this is not healed and cleared up by the immune system, then it goes along to moderate dysplasia, which ultimately leads to severe dysplasia. And here's an example of the very same lesion start to grow. So you see there is a growth, like the lesion is twice the size than here. You also see that the surface seems to be not so much of intact. You see also the surrounding tissue is changed, So it is not so nicely looking like here. And you see something like a thicker wall around. This is called sclerosis. It's like when you have cut yourself, it's the tissue feels a little bit more thicker than normal. And mostly these steps are not revertible. So when you are here at the type for moderate or severe dysplasia, this is not cleared by the immune system. This needs to get out. Because what happens if this not gets out, this will lead to carcinoma in situ, which is actually a real cancer, but a cancer that so far has not spread. You see the immune system will try to get rid of this area, and here's an example of a large lesion, which is a carcinoma in situ. And the carcinoma in situ, when you leave it like that, of course, will lead to an advanced cancer. So far, we don't know how much time it takes from here to there, but we know that this is not something that the progression is from one day to the other. These examples here, you see there is always in that patient, there was 1 year in between, and that is a different patient waiting, saying that she had a lesion for more than 2 years until finally it ended up in a cancer like that. So the four things, you have to know this information, and what you can do now is the surveillance. So first of all, it's the surveillance is inspection and documentation. And I would like to advocate, when you are a child, you are used to that the parents take over action. They take care of you, they bring you to the appointments, they even make the inspection of your oral cavity. But there will come a time that you go out of the home, that you live your life by your own. And so this also belongs to taking care of yourself, to start to do things by your own. So we talk now a little bit about inspection and documentation, and these things go together. The inspection per se is very easy, and I will show you later on. The documentation is most necessary because please don't trust your memory. We do forget what we have seen. And if you don't document what you have seen, then you will forget. And I recommend to use a mouth map, for example, something like that, so that you can note where the lesion was sitting, also probably the size of the lesion, and then you can document. We document with an endoscope system. Of course, this is nothing what everyone has, but your physician can do that. Your physician also can take a sample, like we prefer the brushing, and then the test can be done in the laboratory, and so you finally get the result. So below, these things are done by the physician, but you can do as a patient these 3 steps. You can do the inspection, you can do the documentation, and how can you do that? This is something what I would like to show you now. So the oral inspection, as I said, is not a difficult thing to do. It's like, for example, for the women, the breast examination. Most of the women do not do the breast examination because they are afraid of missing something. But not to do the breast examination is the worst what you can do. So don't be afraid to miss something. It's better to look than not to do anything. And the key of a good inspection is that you have something like a routine, that you start at one point in your mouth, like for instance at the outer side, and then you move to the tongue and the cheek, and then the upper tongue. And I will show you some of the examples later on in the next slides. So here you also see pictures, and you can download these examples from that site. And here are examples how to do that. First, you start to look at your lips, then you look at the labia mucosa, at the upper area, and then the lower area. You look at the cheek and also at the gingiva, at the left side, at the right side. And don't forget the gingiva in the back is very important. And then you start with the tongue and both sides, left and right side, below the tongue, the floor of the mouth, and also the gingiva, that areas, and also the hard palate here, also in the back. And you can also have a look at the pharynx, the oral pharynx, like at the back here. David Cutler already mentioned, sometimes it's also important to use your finger. So when you see something you can touch and you can feel the difference, and there's enough tissue to compare, you have always left and right side. This is very nice in the oral cavity to have. The documentation should be done here in something like that. And then you can follow the lesions, because they should heal within 3 weeks. If they don't heal, go to a physician. I have here an example of cell phones, and that's why do I have that? The cell phones are very nice to have because they have light. So you can try to use that light when you watch your mouth, and then you can do self-examination like that. I know some Fanconi patients have difficulties using their hand, so I find it very useful to use also a spoon when you have nothing else, and you can, like that, is more easy than when you have your fingers that are maybe too small. And with the cell phone, you can also take nicely pictures so that you can remember yourself how the pictures look like. Here's an internet website where you can download an example, and this information will be also available later on at the Slack site, so that you can download and you can write down the date when you have seen the lesion, so that you don't miss the timing. And why is this important? So when we have done our study with more than 700 Fanconi patients, we found out that the majority of Fanconi patients have lesions in their mouth that are just nothing. They are not malignant or even not pre-malignant. This have been 88% in our cohort. And you see here a typical example. You see areas all over the mouth where you see here's something there, oh my goodness, what is that for a mouth? But it seems that this somehow belongs to the disease, and especially the older the patients are. So don't be too nervous when you see a lesion. Document, do a good surveillance, go for a checkup by your physician when the lesion doesn't disappear after 3 weeks, and document with a cell phone picture and with a mouth map, so that you recall where the lesion was sitting and when you have seen this lesion the first time. So I would like to show you some examples. What are the high-risk lesions? Color is an incidence in our cohort. The white lesions didn't progress to cancer, but that have been the red lesions, and also the location where the lesions have been in the oral cavity have been important. So we have seen lesions at the gingiva most likely to be more aggressive, and this is because this tissue is closely attached to the bone, and the chances to develop metastasis in that area is much higher than at the tongue. So please take a good look at the gingiva. Of course, at the gingiva, you can have a lot of infections as well. So, but that's why your dentist has to do a good job to take good care of your gingiva. And also what we have talked about now very frequent is time. Since first appearance of a lesion, we have this time course where we see how cancer arises over a while. So it is very important to be aware of the time from first appearance until the lesion cleared or didn't clear. And again, also the reaction on how the lesion reacts. When you touch it, when you brush your teeth, and when you or when you just touch it with your finger and it starts easily to bleed, this is an alarming signal. Please go to your physician directly. And these are some examples. This is an carcinoma in situ at the palate. Very easy to misdiagnose as an infection. And here, this is also a lesion that you can easily miss at the back gingiva in the upper jaw. And here at the floor of the mouth, where when you touch this area, or when we touched that area, it was very strong, like if you would touch a stone, not what you feel normally in your oral cavity. So also you use your fingers when you do the inspection. So we move again forward to the don'ts. I mean, like, the don'ts are very easy. Don't drink too much alcohol. So this is more the German style, not so much or highly recommend. So if you drink alcohol, think about the amount of alcohol, how much you drink and when you want to drink. So I would not say don't drink completely. We know that when you break down in your body the alcohol, the first metabolite will be acetaldehyde, which can cause DNA damage. So you need to be aware of that. But take care of the amount of alcohol you will drink. Absolutely no-go is tobacco smoke, because smoking has more than 3,000 types of cancerogenics inside. So with the alcohol, you have one cancer-causing agent, and when you smoke, you have 3,000 components that are proven to cause cancer. So this is an absolutely don't. And don't be afraid too much. Use the information that you have. Do the inspection, go to your checkups. So, and now we have the do's, and the do's are very nice and very active to do. So an oral hygiene is something what you can treat and what you can do very easily at home. And there are very interesting studies that even if you use only the finger to brush your teeth, this is beneficial or better than not brushing the teeth at all. Of course, in our days, we have toothbrush, we have toothpaste, and there are a lot of discussions, what is the best toothbrush and what is the best toothpaste. So I don't think that we really need a discussion like that. The most important discussion and decision is to use a toothbrush, to use toothpaste, and to do this regularly. Of course, a good oral mouth hygiene and the self-inspection every week, every second week is a beneficial thing to catch lesions when they start to arise. A regular screen by an expert from the age 10 years on. So what means a regular screening? The recommendation is twice a year. And if you have an oral lesion, then every 3 months is a general recommendation for checkup. The HPV vaccination was already covered by the lecture of David Cutler. And I would like to add a generally healthy lifestyle is important. So take a look at your diet. What do you eat? The physical activity. So very easy, not to exercise, but how many steps do you walk per day? So maybe you can increase that. So, and additional also, not only the diet, also the body weight is important. So avoid overweight. So there are a lot of data that overweight leads to chronic inflammation in the body and misleading of the immune system. So this is something to take care of. And you have heard about mental health and resilience. So how you cope with all these things. It is important to know that you are not alone, that there are experts all over the world to help you and to offer support. And that's really something nice to have in the Fanconi field, because we are really good connected. And this is an example of a German Fanconi patient. So you see he has a replacement of the lower jaw, and he is blind due to his bone marrow transplantation, but still he is a big fighter. And at that time, when the picture was taken, and he was 1 month after surgery, and you really can see still the feeding tube that he had, but he again was in the gym exercising, and he is still alive. He's very well doing, and this is amazing how good he was able to fight against the cancer. And he is a nice example of when you are not afraid, but you take action, how good and how possible survival will be, even when you have an advanced cancer stage. I would like to show you an example, and you have seen these pictures before, how early detection can prevent cancer mortality. So this was a lesion that we detected in June 2016. 1 year later, this lesion started to change, to grow. And again, 1 year later, this was a huge area, and the brush biopsy came back positive for cancer cells. And there was only a little tiny cancer sitting in the middle of that lesion, a 1 millimeter carcinoma in situ. And you can see this is a large lesion. So the diameter was 2.3 millimeters and 1.8 centimeters. So a large lesion, but the surgery afterwards, look at that, very nice result. So a very good, very good surgical follow-up after that. You cannot imagine that this is the same tongue. So early surgery also prevents you from large surgeries. And of course, when this is controlled, you are on the safe side. So we have heard about what we can do against the cancer. Is the information you have. FAF is very supportive on that. You have a good surveillance, not only for your physician, but also for yourself. You can do inspection and documentation by your own. You will need to avoid things, but you can also do things actively against cancer. And with this last slide, I would like to summarize and give you the information where to download this mouth map, and also the pictures of how to do that, inspection and the supportive beneficials. And I would like also to say that FAF we are in the process of making a professional video of self-examination and brush biopsy for physicians, so that in the future you will not only have these papers in hand, but also some digital help, so to perform the oral self-inspection, and also some information for your physician that might help you. So thank you for listening, and I'm happy to take any questions.
Okay, thank you, Dr. Velleuer, very much for a very informative presentation. We don't have any questions yet from our viewers. Oh, somebody raised their hand. Yay, okay. So Rena has a question.
Hello.
Hi, Rena.
Hi. I have a question regarding my daughter. She is 14 and she, we see the dentist, let's say 2 to 3 times a year in our annual visit in Minnesota for the endoscope. And everything's fine. I noticed between my son and her, they have very different mouths. My son has extra saliva, he has no cavities, and my daughter probably has a typical mouth, maybe a little on the dry side. But so she's had many cavities in her baby teeth. But so she's 14, and recently I guess she had a little chip in one of the back teeth, and I didn't realize it. So in the meantime, she had a little bit of a hole, and it could have gone on a month. In the meantime, we got to the dentist, and he said, oh yeah, we need to do, I don't know what it was called, but basically we need to fill that. And he did an x-ray. And again, I'm one of those parents who tries to avoid x-rays unless absolutely necessary. And I didn't really understand truly how many you should do to know that something might be going on. And I really didn't do much of it. And so he did an x-ray and said, okay, she's at risk for mouth decay or tooth decay. So we're going to put this, we're going to seal it, but you need to be really careful. So at this stage, I'm like, gosh, maybe I should have done more x-rays early on. It's just hard to know. And at this point, I feel like they sealed up where that little hole was. And then it concerns me that, was there anything in that hole? And going forward, I just don't know how to look at her situation. I don't know. What do you have to say about any of that?
Yeah, I mean, like, that is a very good point that you point out. So luckily, most of the x-rays the dentists in our days do are dose reduced. So in former days, there have been, because I use a digital camera, and so like I would not be too nervous about these dental x-rays, and they can also do a pinpoint x-ray, so only on the tooth of indication and not the whole mouth. So that is something what you can ask your dentist to do. And generally speaking, a good oral hygiene, there are these patients, so I'm not a dentist, I'm a pediatric hemato-oncologist, but when I see to the experience that we had, like Fanconi patients seem to tend to have dry mouths. And of course, this is makes them prone to get the cavities. But when you take a good care of those cavities, it is you are in good hand, and it is more like when you have these ongoing infections, also the gingivitis, so like when the cavities are more going to be a bigger problem than only on the teeth. So that's the general recommendation.
Okay,
Thank you.
Thank you. And thank you, Anna, for the question. Okay, we've had a few more questions come in. So the first one is, when can we expect a brush biopsy kit to be available for our dentist, and will they be distributed worldwide? And or can one be obtained at this time to take them to the dentist themselves?
So excellent questions. So in Germany, the brush biopsy technology is available and is also paid by the health insurance. Theoretically, the brush biopsy technology is available worldwide because, to tell you the truth, we stole the brush from the gynecological people and also the storage medium. So generally speaking, this technology is available in the whole world. But we need the lab to do the analysis, and we need to find distribution ways. So that's where we work on in the future. And the brush is very nice, but it's not the one and only. So it's the whole package. It's the whole. It is, you can only brush what you see, and that's the big disadvantage of the brush. I like the brush very much because you can point out and catch out the lesion to take a biopsy. But yes, we will work on that. This technology will become worldwide available, and FAF is very supportive, and we are in the process of finding distribution ways for the states and to prepare kits for the physicians. For the time being, I would like to keep the brushing in the hands of the physicians. We tried with a parent last week, the brushing, and the parent was a physician by himself, and it took us half an hour to take one sample. So even though it seems to be an easy technology, and it is easy, you also don't want to do the wrong brushing and to feel fall safe. So that's the back and forth. So we need a whole package. We need training, and training of the physicians, training of the lab, and then we are ready to go.
Thank you. And we have a kind of a follow-up question to that is, where can the analysis be sent? Where are they done now? Are they only done in Germany?
So actually the analysis that we do is a cytological analysis, and there are labs in every country that do cytological analysis. And now we are in the process of finding labs for each country to be recommended, and also labs who are willing to share their samples with us. So the advantage of these samples is that they can be shipped between different labs as well, so without the loss of quality, so that you can always get a second opinion from our lab. Yeah.
Thank you. I have a two-part question from Marcos, who says that there seems that special UV lights for oral screening, either infrared or UV lights, are these special lights really useful? And then in addition, could the use of special lights, could they be harmful in the long run?
So for Fanconi anemia, no one has checked if these lights are harmful. Theoretically, I don't think so. These lights are useful for the untrained eyes to catch lesions. But it is also, so as I said, I'm not a dentist, I'm not an oral surgeon, I'm only pediatric hemato-oncologist. And when you start to look in the mouth and when you start to look carefully, you will easily see what you have to see. These slides might help, but they also sometimes confuse you because they also point out where you have infections and something like that. So there is an advantage, but I would use these slides also only with a physician, not by yourself.
Oops.
I don't
unmute myself. Okay, would you recommend, this is from Lisa, would you recommend that their teenage 13 self-examining, or is it better that they did it for him? And how often is it practical? He's seeing the ENT every 6 months and is pre-transplant.
A very important question. Actually, I think it depends on the child. So I think we have not to overwhelm our patients, our children, with too much of information and too big burden. So I think it's more of a dialogue between your child and you. So you can offer the information, you can discuss, do you want to do it? Do you want to do the inspection by yourself? Do I have to do the inspection, and so on? So I think there are some patients who would like to do it more by themselves. But I mean, like if the mother is checking the mouth once a month, this is enough. The age of 13 is not to be too much of nervous about when you are not transplanted. We know that there are some few patients between the age of 10 and 20 who develop cancer. All of those patients have been transplanted and had a difficult transplant. So the untransplanted Fanconi patient, they seem to develop these cancers later on.
Okay, thank you. Our next question is from Lynn, asking if you can discuss your recent publication and the fact that 63% of the worrisome lesions found through the brush biopsies were detected at a pre-malignant stage or stage 1 when they could be successfully removed.
Thank you, Lynn, for this additional information. Yes, this is very important information and also shows the big advantage of a good surveillance. So I've shown you the data, the historical data, where cancers have been diagnosed at late stages. And I would like that we, all of us, think about these things in the whole context of it's not only the brush that was able to catch these early stages, but of course it was the whole setting. It was the information, it was the looking in the mouth, and it was never don't judge the lesion that you saw. So when you go to an experienced ENT, what they do is they search for cancer to cut out. And what is the big advantage of the brush is you just brush everything what you see. And by doing that, you find early stages. And that is what we call really early detection. And yes, we have seen 63% of early stages and stage 1, and the surviving of those patients is enormous. So the longest follow-up that we have is longer than 12 years now. So, and this is an enormous and a very good information. So it doesn't mean that when you have these cancers that the rest of your life is gone. So when you are at early stage and when you are detected these cancers early, then you are on the safe side. And then cancer can be cured and controlled.
Thank you. We need to hear that. It's very hopeful and helpful. The next question is about if FA patients tend to have dry mouths, is there a recommendation for any mouth rinse and what products would be used, or any other products besides a mouth rinse to help the dry mouth?
Yeah, I mean, like what you can do is you can choose chewing gums to enable to produce a mucus. You can drink oral rinses. I would be very cautious because most of the oral rinses contain alcohol. So keep your mouth wet is always good by drinking. And by not eating too much of sugar, because this also gives growth advantage to bacteria that are not beneficial. So this is more the general recommendation. And I don't have a special product to recommend on that side.
Okay, my guess is that some of our listeners, attendees do, and maybe they could share those on the Slack channel. So if any of you have a good oral rinse and toothpaste, I think as well, that you would recommend, you can share that on the Slack channel. Another question about x-rays and braces. So can you speak to how often somebody should be x-rayed? Maybe you did that a little bit earlier, but and also braces, what to watch out for. And
so we have seen both. We have seen very bad mouths with fixed braces. So when a patient developed severe infections and reaction to the fixed braces. And we also have seen patients where the fixed braces really had a huge benefit. So generally speaking, when the child has really bad teeth that stay at the very wrong directions, they can cause damage and chronic damage at the tissue. So, and you don't want to have that. So you need to discuss with your dentist what is the best way to do, and maybe you try a fixed brace. And you see how the mucosa is reacting on that. But as soon as you see that there are chronic lesions or inflammation, get rid of them, because chronic damage, chronic lesion, you don't want to have. And in terms of the x-rays, I mean, like, you really have to think about each x-ray that you do perform. But we know that Fanconi patients also receive radiation therapy for oral cancer, and these dosages are a lot higher than an X-ray. So it is not when you have done one X-ray that this increases your chance for getting cancer. There you have different issues on that, and different factors that contribute to cancer more. So when your dentist really thinks that you have to do that, you should do that. Yeah.
Okay, and along those lines, is there any foods that would be advantageous to stay away from, like hot sauces, or any foods that would disrupt the oral mucosa?
This is a very delicate question, because I don't know any study on that. So there are studies about hot drinks for esophageal cancer. So when you drink too hot products, they can do tissue damage. So I would like more to advertise everything what your child likes. You can go along with, because mostly when you do damage to yourself, you get pain. This causes pain, and when you pain is an alarming signal. And when your child feels the pain, then you should stay away from that. So when you drink too hot coffee, too hot tea, that you feel the pain, and this is for sure not beneficial. So, but in terms of, we also know that chili, for example, has some antimicrobial effect. So, and I don't know if this is like a pro and con. So there, from my point of view, there is no study, or to my knowledge, no study on that. So.
Okay, thank you. Our next question is, do you have anything to say about the roof of the mouth having a cobblestone look to it or affect to it? This person has been told that her kids have a mild case, but otherwise nice mouths. So a cobblestoning, kind of a bumpy appearance to the roof of the mouth, the palate.
Yeah, this is something what we see very frequent in FA. So it is more like something to document. So and it is sometimes also what we see at the tongue, that what people call landscape tongue, that some people have that. So this is something not like an anomaly. This is just something to have as soon as as long there's no change. That's your personal attitude, like the color of your eyes. So there's no association to any increased risk.
Okay, thank you. Apparently there's been a question in Slack answered whether having a cleft palate surgery increases your oral cancer risk.
So I don't know the data on that, but I don't think so. So when we talk about the esophagus, so some of the patients, Fanconi patients, have been diagnosed with esophageal fistulas, and it is more important to repair those defects, because these defects are more like problems causing than the surgical repair.
Okay, and then lastly, can you speak to the importance of tissue donation if somebody is diagnosed with a cancer or maybe going to have a biopsy, what they can do to help advance research with that?
This is a question of huge importance, and I'm very happy that this has been raised. So in Fanconi anemia, we very often hear we cannot judge on that, this or that drug, we don't have enough sample size to make a clear answer. So our team has proven that this is not true for Fanconi, because we are connected. We have been able to see more than 1,000 Fanconi patients. We have been able to take a lot of brush samples. So, and we have been proven that we have statistically highly significant results. So I would like to encourage each Fanconi patient to get in touch with FAF or the local patient support group in terms of when they are diagnosed with oral cancer, because this tissue is highly needed to do screening on, and also research on, to find out what will be the future therapeutic products to offer that are not the typical chemotherapies. And there are many, many new promising drugs, but we need more information, because in the past we thought that the Fanconi cancers are comparable to the general population. And it seems now with more advanced technologies that they differ. And to prove that, we need samples. And I very much like the idea and what FAF is doing, that we have dedicated labs where all the samples are sent to, so that we have an enormous amount of and a large sample size, so that we can answer those questions. And when we work together, this is absolutely feasible. So contact the local patient support group, and then we can work out how to process these samples.
Thank you. We have a hand raised by Johanna, and we'll let her ask her question. This might be one that needs interpreting, so there might be a little bit of a lag time.
Hola.
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 Hablaría en español, hablo en español. Bueno, mi pregunta es la siguiente. A mi hija hace unos meses atrás tuvo unos problemas respiratorios y lo llevamos con el neumólogo. Y le mandó,
Yes, I can hear.
Le mandó un inhalador que es de formoterol con budesonida de 25 microgramos. Al iniciar su tratamiento no tuvo ningún problema, pero ya al tener 2 o 3 meses con el tratamiento, a ella le empezaron a salir unas llaguitas en la boca. El neumólogo me dijo que era relativamente normal por el medicamento, pero cuando ella lo suspende, se le quita y cuando lo vuelve a usar el medicamento, le vuelven a salir esas llaguitas, aunque ella hace enjuagues bucales con bicarbonato de sodio.
Okay, we should get a translation of that pretty quickly in our chat box. So if you'll just hold on for a moment, we
I
will
had
do it.
I understood the English, so I could answer. Or
You understand Spanish?
no, I mean like I hear the English translation.
Oh, you hear it.
Yeah.
Okay.
So I can answer.
Wonderful.
So I recall or I summarize. So the patient received due to some lung issues inhalator, and then when she tried the inhalator, she had lesions in the mouth, and without the when she stopped the medication, the lesions gone, and when she again used the inhalator, then the lesions came back again. So I assume that this was have been steroids that she used, and this is very common. That we see very frequently. So what she can do is when she uses the inhalator, she can rinse the mouth by just drinking a sip of water like I do now. And then rinse the mouth so that the steroids do not stay on the tissue, so that they get cleared off. She should try that. Mostly this works.
Sorry, el intérprete no me tradujo. Sorry. Sí, claro, muy bien.
Yeah.
Sí, te escucho.
Yes, I can repeat. So probably this have been steroids that she used. So she should, after the use of the steroids, the inhalation, she should drink some sip of water or rinse the mouth to get rid of the steroids that stay in the oral cavity and not gone through the lungs. And that should get rid of the problem.
Ok. Sí, es lo que hemos estado haciendo, pero a veces le salen las llaguitas y a veces no. Aunque ella siempre hace sus enjuagues bucales después de hacer las inhalaciones.
That is very important. So I mean, like this is very common because it shows how a local immune suppression in the oral cavity can lead to problems. But again, everything that comes and goes after 3 weeks, you don't need to be afraid of.
Ok, sí, ella le duran unos 3, 4 días, se le quita.
Yeah, perfect. Then don't worry too much.
Oh,
Okay.
Muchas gracias, muy amable.
Thank you.
Wonderful. Thank you for that. And thank you for the interpreters. We really appreciate you very much. Okay, Dr. Velleuer, I think, oh, we have another hand. Nope. I think that's it for questions, unless we'll just give it a few seconds, unless you have some closing remarks at all.
I'm very happy, I must say, seeing the progress that have been done in the last 20 years gives me really hope for the future. And also to show that we are able to diagnose these cancers early enough really makes me very, very proactive for the future. And I would not like the idea that people are too afraid of these cancers.
Thank you. Those are good parting words. Okay, thank you so much for your time. Thank you for the great information.